All right, good morning, everyone. I think we will get started. Welcome to Grand Rounds. My first comment has to be that I'm actually a pinch hitter for Betsy Hirsch today. Betsy is Amy's mentor on this project and would ordinarily be doing this. She apologizes for not being here. She's actually giving an invited talk of her own that just happens to conflict. So, again, you have the B team here today. I'm more than happy to introduce Amy Beckman. Amy is known to virtually everyone in the room here. She is a fourth-year resident. She came to our program having received her MD from UCSF. After that time, she worked in a number of different positions in healthcare, including one that was very interesting, which was with the National Marrow Donor Program, in which she helped facilitate bringing together hematopoietic stem cell donors and recipients. I think that's an experience that has served her well in residency and will obviously serve her well when she is a HemePath Fellow next year. Amy has been very active in administration of our program. She was a co-chief resident last year. She was instigator and leader of the Molecular Pathology Journal Club. She's typically gone above and beyond in service to our division. As well, she is the CAP Committee for Personalized Healthcare. She is the junior member on that committee, which is a great experience for all residents to be on CAP committees. She has a number of publications and presentations to her CV, and she's also juggling a couple of ongoing research projects, one of them which is with Dr. Betsy Hirsch. And so she will be talking about some of these projects, particularly this one that she's working on with Betsy, the cytogenomic landscape of myeloid disorders in Down syndrome. So welcome, Amy.
Thanks so much, Dr. Dolan, for that introduction. I'm really excited to be here today to talk to you about this topic. And I'm going to kick things off here with first figuring out how to use the computer. Can I just use the arrows?
Maybe
I'll just use this.
It worked before.
I don't know, can I just use the arrows?
Yeah, sure.
You can, if you want to just do, I don't need that presented to you. Mike, I wanted that.
There you go. Yep.
There you go.
Okay. Okay, so here are a couple of objectives for my talk today. I just want you to understand by the end of the talk that children with Down syndrome are at extremely high risk for myeloid disorders. I'm going to describe to you that some of the unique clinical and pathologic features of myeloid leukemia in children with Down syndrome. And then finally, I'd like to discuss the role of cytogenetic testing in risk stratification and management of myeloid disorders, with a particular eye to myeloid leukemia in kids with Down syndrome. So I'm going to kick things off here with a case. This is the story of a little girl with Down syndrome who was followed by hematology oncology over at Minneapolis Children's for thrombocytopenia. So she went in for a routine appointment one day, got a CBC drawn, and the CBC showed 20% blasts. This was confirmed on a peripheral smear. So some of this blood was sent for cytogenetics testing. And it happens that our cytogenetics lab here at the U serves as a reference lab for Minneapolis children. So that sample came here. And a G-banding study was done. And this study showed that, you can see up in the corner there, that there were some deletions in chromosome 5, as well as a copy of the long arm of chromosome 1 here that was stuck on the end of chromosome 14. So there's an extra copy of part of chromosome 1. And then finally we can see that an extra copy of chromosome 21 here at the bottom, confirming the patient's known diagnosis of Down syndrome. So it's become routine in our cytogenetics lab here on oncology specimens to run DNA microarray, specifically array comparative genomic hybridization. And that's exactly what was done in this case to further characterize this patient's cytogenetic abnormalities. So in this picture here, these are some of this little girl's findings. You can see on the left-hand side here, this is just a schematic of chromosome 1. Along this wiggly line here represents our patient's DNA, and underneath the wiggly line you can see a straight line right down the middle of this chart. That straight line, as long as our patient's results conform to that 0 line, we know that there are no copy number variations in the patient's DNA. However, if you look down toward the more distal arm, distal long arm of chromosome 1, you can see a deflection of that wiggly patient line over to the right. And this just indicates that there's an additional material from the distal arm of chromosome 1. So that confirms what we saw by G-banding and further characterizes a little more precisely where the breakpoints are. This is what was seen on chromosome 3. So if you remember, we were able to see that abnormality on chromosome 1 in the G-banding study, but we didn't see this on chromosome 3. And this is because G-banding has got higher resolution. DNA microarray is higher resolution than G-banding is. And so we could see on chromosome 3 an abnormality here in the long arm of chromosome 3. In this case, there's a deflection of the patient's wiggly line here to the left, indicating that there's a loss of a material of about 117 kilobytes in the long arm of chromosome 3. And again, that wasn't visible by G-banding. Oops, I'm sorry here, let me show you. I want to just go on to chromosome 5. If you'll remember, we were able to see this abnormality on G-banding, but it just couldn't be very well characterized on that particular study. But DNA microarray is able to characterize this quite specifically, and we can now see that there's actually 2 deletions in the short arm of chromosome 5. And this is a close-up of those deletions. We're just homing in. Again, you can see a deflection from that 0 line to the left, indicating that this is a loss of material, both in this more proximal region as well in this more distal region of chromosome 5. And then finally, there was a gain of all of the material in chromosome 21, again consistent with this patient's known diagnosis of Down syndrome. So this little girl also had her peripheral smear reviewed, and all of the findings were taken in together to form an integrated diagnosis, and she was diagnosed with myeloid leukemia and Down syndrome. So in 1957, there were a couple of pediatricians here at the University of Minnesota, Dr. Robert Good and Dr. William Krivitz, who reported their observations that leukemia is dramatically increased among kids with Down syndrome compared with children who don't have Down syndrome. So it's so increased, estimates range from about 10 to 100% that times the risk of that children with Down syndrome will acquire an acute leukemia compared with kids without Down syndrome, such that by age 5, 1 to 2% of kids with Down syndrome will have developed an acute leukemia. So the interesting thing is that among kids without Down syndrome, acute lymphoblastic leukemia is much more common, such that there are about 6 to 7 cases of ALL for every case of AML among kids without Down syndrome. And that's in contrast to kids with Down syndrome, for whom that ratio is more about 1 to 1 or maybe 2 cases of ALL to every 1 case of AML. It's quite a different ratio. I'm going to spend a little bit of time here emphasizing to you that myeloid leukemia, when it happens in Down syndrome, is really a unique disease. It's quite distinct from myeloid leukemia outside of the Down syndrome setting. And it's so unique that the World Health Organization's classification of hematopoietic tumors considers this entity as a distinct, independent subtype of leukemia called myeloid leukemia associated with Down syndrome. So to begin, myeloid leukemia and Down syndrome has a unique age of onset. It's quite a bit younger than AML in the general population. So I think most of us know in this room that AML, although it can occur among young children and very young children, AML is really a disease of old people. It's got an average age of diagnosis of about 68 or 69. So in contrast, there's a little bit of a blip down here among infants. Infants can get AML, but then that risk kind of declines until about age 10, at which point it starts rising again until people get older. But myeloid leukemia of Down syndrome happens by the age of 4 or 5. Secondly, myeloid leukemia of Down syndrome is characterized by this kind of mysterious transient preleukemic syndrome called transient abnormal myelopoiesis, or TAM. So the WHO definition of this is that it's a disorder of newborns with Down syndrome that presents with findings that are indistinguishable from full-on overt myeloid leukemia. Kids with this condition, it affects about 10 to 30% of newborns with Down syndrome, and it's usually diagnosed when a CBC or a peripheral smear is done in the first days of life. So neonates are typically diagnosed between age 3 to 7 of life with this disorder, and the blast counts, the morphology of the blast, the immunophenotype of the blast look all the world like acute leukemia. And all cases have this interesting phenomenon that they have an acquired mutation in the GATA1 gene. So I have a chart here that's going to help me explain to you the natural history of this disease among kids with Down syndrome. So we start here with a fetus with trisomy 21, and here at the top are 10 to 30% of kids who develop TAM. And at the bottom, we've got the 70% of children who don't develop TAM and who are healthy and just carry on like normal. So TAM is clinically variable. There's a pretty good set of patients who really don't have any symptoms at all. They're just diagnosed it's an incidental finding on a blood smear. And this in the literature is referred to as silent TAM. But there's a subset of patients who do have clinical symptoms like organomegaly or thrombocytopenia. And unfortunately, there's a subset of those children who are really quite ill with massive hepatosplenomegaly that can interfere with respiratory function, pericardial and pleural effusions, coagulation derangements. These children are really ill. And sometimes these kids are treated with chemotherapy. So just 1 or 2 short courses of cytarabine in these kids can clear up the blasts in about a week, and the clinical symptoms resolve, and these kids, many of these children do just fine. But I'm sad to say that in 20% of children, TAM can be fatal. And sometimes it's fatal in the setting of another disease, like congenital heart disease, which is really common among kids with Down syndrome, but a lot of times it's ascribed to the TAM itself, because TAM results in the infiltration of the liver sinusoids with blasts, so these kids get liver failure and they die. But the good news is among the 80% who don't die, TAM can resolve. The abnormal clone seems to go away, the blast count reduces, and within 3 to 6 months, any symptoms that they had resolved, and they're really in good shape. Unfortunately, though, these kids are not out of the woods yet. So here's our kids who don't develop leukemia, but about 20% of these kids have persistence of their abnormal clone. It can't be detected, even using very sensitive techniques, but this clone persists, and eventually, within about 1 year to 3 years, these children go on to develop overt leukemia. So 20% of children with TAM do develop leukemia. It would be great if we could somehow predict which kids with TAM are going to go on to develop leukemia, but we just can't at this point. Many people have tried to figure this out, but nothing seems to associate with the later development of leukemia. Not the size of the abnormal clone, not specific cytogenetic abnormalities, not specific genetic abnormalities, not the administration of chemotherapy. We just don't know why these kids go on to develop myeloid leukemia. But you know what, I'm going to skip that part here. All right. So myeloid leukemia and Down syndrome has a kind of unique morphology and immunophenotype. It tends to present in an indolent manner and starts off with a kind of myelodysplastic type syndrome. Once overt leukemia develops, it tends to take the form of a very rare subtype of leukemia in which the blasts resemble abnormal immature megakaryocytes called megakaryoblast. So there's megakaryoblastic differentiation in about 50 to 70% of cases of MLDS. Now, I think it won't surprise anybody here that with this very unique clinical picture, there are very unique genetic abnormalities in MLDS. So first of all, I want to remind everybody that the karyotypic, that cytogenetics really is a cornerstone of diagnosis in AML, and this is particularly true among children with AML, in whom these recurrent, balanced cytogenetic rearrangements are quite common and occur in, this is kind of split up here, but over 50% of patients. So young children with AML tend to have core binding factor leukemias here, or they might have acute promyelocytic leukemia with the translocation 15-17. Rates of balanced rearrangements involving chromosome 11, that KMT2A gene that's been renamed from its old name, MLL. Those are extraordinarily common among young children without Down syndrome who develop AML. But these recurrent balanced rearrangements are virtually absent from MLDS, so this is a really different disease. But while these are absent, something else is quite common. Acquired mutations in the GATA1 gene are ubiquitous among kids with both TAM and MLDS. So what is GATA1? Well, it encodes a transcription factor. It's critical for myelopoiesis, especially the formation and differentiation of erythrocytes and megakaryocytes. It's really critical for normal megakaryocyte development, and when it's not present, the megakaryocytes are, in experimental studies, are abnormal, and they tend to proliferate out of control. In Down syndrome, in leukemia and Down syndrome, there are a whole bunch of different mutations that can happen in the GATA1 gene, but they tend to cluster around the N-terminus, and they all seem to cause truncation of the GATA1 protein, such that we get the formation of this truncated protein. So here's the normal length of the gene, or the normal length of the protein, here's the shorter protein. It's referred to as GATA1S, and when animal studies have been done on animals that express only this GATA1S form of the protein, these animals have very abnormal megakaryocytes, and again, a lot of proliferation of the megakaryocytes. GATA1 is located on chromosome X. All right, so let's go back to our flow chart of the natural history of myeloid leukemia and Down syndrome. I think it's useful to think about the leukemogenesis in Down syndrome as being a three-step process. So our first hit here is trisomy 21. And trisomy 21 in and of itself causes abnormal megakaryopoiesis. So when people have looked at livers in animals and humans with trisomy 21, you can tell that those megakaryocytes are not normal and they're proliferating too much while not differentiating. So this trisomy 21 seems to be the first hit. Secondly, we've got these somatic GATA1 mutations. These are quite interesting. You'll see that I've put this call out here in the fetal time period of life. So these truncated GATA1 mutations happen during fetal development. They're detectable in some cases, by 21 weeks of gestation. And there can be more than one. So it seems like trisomy 21 somehow induces or selects for these clones that have GATA1 mutations. There can be as many as 5 abnormal GATA1 mutations in a baby with Down syndrome. But these abnormalities alone they seem like enough to produce TAM, but not quite enough to cause a baby to develop acute leukemia. For that, we get persistence of this clone, and then additional genomic or genetic abnormalities happen. That clone might be selected for, and at that point, the child will develop MLDS. So these additional genetic abnormalities can be thought of as a third hit. What are the other somatic mutations besides GATA1 and TAM and MLDS? Well, a lot of researchers have tried to figure this out. We still don't really know what's going on with this disease, but I'm going to present just briefly a study that compared samples from patients with Down syndrome and TAM, Down syndrome and acute leukemia, as well as patients who had a subtype of leukemia, acute megakaryocytic leukemia, not in the setting of Down syndrome. And they did a bunch of different sequencing studies on these samples, and they found that, first of all, GATA1 mutations were ubiquitous among the TAM and MLDS samples. In TAM, there were only a few acquired mutations in other genes, and none of these were recurrent. But in MLDS, there were numerous mutations in other genes, and many of these did occur in more than one case. So here's the main figure from that study. This is this box here represents the samples from patients with TAM. Each of the columns is a patient, and each of the rows represents a gene. And these colored boxes here represent gene mutations. You can maybe see from the back, I know it's quite small, but this is GATA1 here, so you can see that every sample from a TAM patient had a GATA1 mutation. This is trisomy 21, every patient had Down syndrome, so they all had an extra copy of chromosome 21. And then really there's a few mutations, but not too many. I'm going to scooch that box over here and then show you the samples from cases with MLDS. There are many, many more mutations among these patients. So overall, this suggests that probably trisomy 21 and GATA1 mutations are sufficient for development of TAM. But to develop acute leukemia, you really need mutations in other genes. So what were these genes? These investigators tried to start figuring that out. They selected a bunch of the genes in which recurrent mutations were seen in these patients, and they grouped them according to function. They saw mutations in genes that were critical to the cohesin complex. They saw mutations in epigenetic regulators, mutations in proteins that are parts of cell signaling cascades, and then a host of other mutations in genes like TP53 and WT1. And they speculated that these are the third hit mutations that are critical for leukemogenesis in these patients. All right, so lastly, I'm just going to tell you about one last really unique aspect of myeloid leukemia and Down syndrome, and that is that the outcome among these patients is quite different from the outcome in patients without Down syndrome. So first, I'm going to show you a survival curve from pediatric patients with acute myeloid leukemia, but this is all comers, so all different subtypes of AML and all different patients. Probably some of them had Down syndrome, but the vast majority did not. And this is a really nice figure, I think, because it shows overall survival plotted against the years of following treatment for these kids' leukemias. And each of these lines represents a different COG, Children's Oncology Group study, or a legacy study, a study from before the COG existed. And you can see that back in 1975, this disease had a really dismal prognosis, but with today's modern chemotherapy protocols, kids with AML outside of the setting of Down syndrome have complete remission rates of about 85 to 90%. So this represents just wonderful improvement for this disease. Unfortunately, however, overall survival rates, even among kids who do, even with all those children who achieve complete remission, overall survival rates still hover right around 65% at 5 years. So really, it's still kind of a dismal diagnosis. So let's contrast that to MLDS. Here's a survival curve for an overall survival curve for a bunch of patients who were involved in a recent COG study. And we can see that so there's two different studies portrayed here. And you can see that the 5-year, here, I think I drew some lines here. Nope, I didn't. So the 5-year survival for these patients, the overall survival, not just their complete remission rates, the overall survival for these patients hovers around 85 to 90%. This is hugely better than the overall survival in kids without Down syndrome. So why is this? Well, people speculate that's probably because the leukemic blasts of kids with Down syndrome are uniquely sensitive to chemotherapy. There's a bunch of literature on this topic, but I think I'll just leave it to say that when in vitro studies are done and leukemic blasts from kids with MLDS are compared with leukemic blasts from kids without Down syndrome, the leukemic blasts in Down syndrome are just much more sensitive to a number of agents that are routinely used for treatment of pediatric AML. So this is great because it results in improved outcomes. The only downside is that in vitro, kids with Down syndrome are just exquisitely sensitive to chemotherapy. So they have increased morbidity and mortality associated with high-intensity treatment, the type that's usually used with kids without Down syndrome to treat leukemia. So with chemotherapy, these kids suffer high rates of profound myelodepression. This can lead to infections. They also get a lot of cardiac toxicity, which can be really devastating in this group of kids with high rates of congenital heart disease. And then finally, bone marrow transplant really does not play a role, for the most part, in treatment of MLDS because the process of ablating the patients just hits the kids so hard. So these numbers are from a recent study of bone marrow transplant among kids who had relapsed with MLDS. The 3-year overall survival among those kids with Down syndrome who got transplanted was 21%, compared to about half of children who didn't have Down syndrome and who were transplanted for myeloid leukemia. All right, so here's another survival curve from a different study. This was from an enormous study of over 400 children in Europe with MLDS. And we can see again that the survival curves for this particular group of patients at 5 years was a little bit lower than what I showed you on the other curve, but still quite high, 78 to 80%. And with this figure, I just want to hit home to you that we've kind of got a couple of groups of patients among this cohort of children with myeloleukemia and Down syndrome. First of all, we've got the 80% of patients who have really good outcomes, but they're all very vulnerable to toxicity. So we can treat them with reduced intensity chemotherapy, and they still do very well. This helps cure patients while minimizing toxicities. Unfortunately, however, there's this approximately 20% of patients who either have refractory disease or acquire relapse disease, and these patients do really poorly. You can see by the way that so the blue line here is event-free survival, the red line is overall survival. Do you see how these track so closely? This indicates that once kids develop refractory or relapse disease, they're really not salvageable. Once kids relapse, they die. So our job in this case is to figure out which kids have this bad prognosis and which kids have a better prognosis and can be treated with these reduced intensity chemotherapy regimens. So just really quickly to hit this point home, this is the summary of a small study of kids kids with Down syndrome with acute leukemia who either had relapse disease or refractory disease. And this study found that no matter what you treated these kids with, whether you gave them BMT or did intense chemotherapy, 3-year overall survival was only about 26%. And this is kind of similar to what happens among kids without Down syndrome with relapsed AML. So most of these treatment failures in this particular study, most of these kids had gotten reduced intensity chemotherapy regimens, and treatment failure was thought to be due to disease progression in these kids, not necessarily treatment-related toxicities. Okay, so all of this is to say that in this population of children, early achievement of a durable, complete remission is really critical, because once these children relapse, they do very poorly. All right, so here's that survival curve again of kids, all comers, not just kids with AML, all comers with AML, and you'll remember this dramatic improvement of outcomes over the years. But I want to point out to you that improvements in outcomes among this population of kids are due to better supportive care and intensification of therapy with non-targeted agents. So for kids with AML, we are still using chemotherapeutic agents like cytarabine and anthracyclines that were around in the 1970s. We don't have targeted therapies for these kids. The only thing we've got in our armamentarium is to increase the doses of chemotherapy, or to give these kids bone marrow transplants, which you know is not really an option among children with Down syndrome. So we're in this situation for Down syndrome kids. If the only thing in our armamentarium is to increase the intensity of treatment, but we know that we can't slam these children with intense chemotherapy because that causes too many toxicities. Successful treatment of myeloid leukemia and Down syndrome really depends on identifying the patients for whom the benefits of intense chemotherapy outweigh the risks of toxicities in this vulnerable group of patients. So to do that, to figure out which group of patients is which, we need prognostic markers. I'm going to take just a second here to talk to you about cytogenetic testing and the key role that it plays in prognostication and treatment selection for all patients with myeloid disorders, adults and children alike. But before I do that, I'm going to tell you a little story. So this is Dr. William Schechter. He is currently Professor Emeritus of Surgery at University of California at San Francisco, and he happened to be my attending on my very first clinical experience in medical school. So he was my attending on the general surgery rotation at San Francisco General Hospital. And the very first week of my rotation there, he gathered all of us trainees up into a corner, and he said to us, "What does every patient deserve?" And we stood there, sort of quivering in our scrubs, like deer in the headlights, thinking, this was not on step one. We don't know what every student, what is he going for? We don't know what every patient deserves. What can this possibly be? Well, the answer was, every patient deserves a diagnosis. I will never forget. So let's fast forward now to residency. Many of you know this gentleman. This is Dr. Ken Batts. He's one of the GI pathologists over at Abbott. And every time Ken Batts comes over to give us a lecture on GI pathology, he starts his lecture off with, diagnosis is the art of distinguishing one disease from another. So what is a diagnosis in this age of precision medicine? We are now beyond the stage where making a diagnosis simply by labeling a disease entity is sufficient for our patients. We give diagnoses in an attempt to describe the biology of a disease and in an attempt to predict the behavior of that disease so that we can choose the appropriate treatment for our patients. And that's exactly what we try to do in myeloid disorders, where I think this whole idea of prognostic markers is particularly important. Now, in myeloid disorders, we have a small number of patients who have a disease that's characterized by a specific targetable gene mutation or chromosomal abnormality. These patients have something like chronic myelogenous leukemia with BCR-ABL rearrangements or acute promyelocytic leukemia that can be treated with ATRA. These patients can get targeted therapy directed at their underlying abnormality. But for the large majority of patients with myeloid disorders, we don't have that type of targeted therapy for these patients' underlying genetic abnormalities. For these patients, treatment selection is, at least partly, based on prognostic markers. And we use these prognostic markers to identify groups of patients with high-risk disease. These patients go on to get high-risk therapy, which might include a lot of chemotherapy or bone marrow transplant. And then the standard or low-risk disease patients can just get standard risk therapy. All right, so I'm just going to quick remind you of some other situations in which we use prognostic markers in myeloid disorders. So this here is a summary of the cytogenetic component of the International Prognostic Scoring System for myelodysplastic syndromes. MDS is a really heterogeneous group of disorders. Some patients do okay, other patients go on to develop profound cytopenias and eventually acute leukemia. To try to predict which patients are going to do well and which patients are going to do poorly, which patients need a lot of chemotherapy, which patients maybe need none, just some observation. Clinicians often use this revised IPSS scoring system, which includes as a key component cytogenetic markers seen in each individual patient's disease. And we don't have scoring systems like this for acute myeloid leukemia, either for adults or children, but what we do have is the WHO, which subdivides acute leukemias according to their prognosis. In particular, we have a large number of subtypes of AML that have specific recurrent genetic abnormalities, and a lot of these are associated with a specific prognosis that helps the clinician decide how intense, the intensity of treatment that an individual patient needs. We really don't have a system for children with AML. So I just put here some of the markers that are used to decide whether a child is high risk or low risk, and how the Children's Oncology Group assigns children with acute myeloid leukemia to high risk or low risk treatment arm. Now the strongest predictors of outcome among kids with AML, not just Down syndrome, but outside the setting of Down syndrome, are persistent disease after injection chemotherapy, and the presence or absence of some of these good prognostic markers, either in cytogenetics or molecular markers. But at the moment, in the current time, we just don't have any prognostically significant cytogenetic groups, or really any factors at all, for children with acute myeloid leukemia in the setting of Down syndrome. We can't tell which kids are going to do well and which kids are going to do poorly. So this is where I'm going to start to talk about the projects I'm working on with Dr. Hirsch. We hope to start trying to come up with an answer to that big question of prognostic markers in acute myeloid leukemia of Down syndrome. First, I'm going to talk about a really big study that I've been so lucky to be involved with Dr. Hirsch. And this is a study with the Children's Oncology Group, or the COG. For those of you who aren't familiar with the COG, this is a clinical trials group devoted exclusively to child and adolescent cancer research. It's funded primarily by the National Cancer Institute. It's been in place since about the year 2000, when it resulted from when a number of different cooperative research groups banded together to form the COG. So it goes back farther than 2000, but this is when the name originated. It includes 200 institutions in North America, Australia, New Zealand, and Europe. 90% of children with AML in the United States are managed by one of these institutions. That's part of the COG. So that's the what, who, where, when, and why. And now, what, who, where, and when. And I just want to say, if you're wondering why, this is why. All right, so the study that I had the good luck to work on with Dr. Hirsch is called 1531, Risk Stratified Therapy for Acute Myeloid Leukemia and Down Syndrome. Now here's what this study looked like. The study investigators enrolled many different children at various clinical trial sites. All of these kids had MLDS. They were treated with induction chemotherapy, and then they were tested for minimal residual disease at day 28 following the initiation of induction therapy. And the idea to use this as a prognostic, the presence or absence of minimal residual disease, to choose therapy for kids with acute myeloid leukemia. This idea was based on a previous study that showed that MRD positivity in kids with MLDS was a poor prognostic marker. So they tested kids for minimal residual disease. Those who did not show minimal residual disease were classified as standard risk. So again, this had nothing to do with cytogenetic findings in these kids. This is purely presence or absence of minimal residual disease. So if minimal residual disease was absent, these were standard risk kids and they were treated with a reduced intensity chemotherapy protocol. If they were MRD positive, the kids were classified as high risk and they went on to receive high dose, high intensity chemotherapy of the type that a kid without Down syndrome would get. And then the study started to look at 2-year event-free survival. Now what happened, unfortunately, was that this group of kids, the study underwent an internal review a few years after it was started, and they noticed that the children on this standard risk arm were relapsing. They were relapsing at a rate that was higher than what was expected based on studies of MLDS in the literature. And because it was higher than what was expected, the study was halted. They stopped the study, they regrouped, and they decided that no longer would these kids of standard risk, they'd still do the testing for minimal residual disease, but these kids would not be put on reduced intensity chemotherapy. Instead, they just undergo whatever was standard of care at their own institutions. But this phenomenon, this event, really shook the investigators of this study, and they said to themselves, so clearly MRD is not the whole story. There's something here that we're missing. There's something about these standard risk patients that makes them high risk. Yeah, Dr. Corbell.
Sorry to interrupt. How does the MRD define? How do they define MRD?
0.05% of events on flow cytometry. Does that sound right?
I think they use a centralized reference lab. It all goes to
They did.
Logics. Mike Logan does it all.
You are exactly right. Yep, so it all went to a centralized lab where they use flow cytometry to look for minimal residual disease. Okay, so the investigators asked themselves, what are we missing? And it made a logical sense to start with the cytogenetics of these patients. So the cytogenetic testing in the COG, whether it's this trial or any trial in the COG, that testing undergoes central review by 2 cytogeneticists. One is our very own Betsy Hirsch. The other is a woman named Susanna Raimondi, who works at St. Jude's Children's Hospital in Tennessee. And so this is where I got involved with the study. We decided to look at the cytogenetic abnormalities among these kids. The aims of our analysis were to identify single abnormalities or combinations of abnormalities that were associated with high or low risk of relapse, and then to generate hypotheses about what genes might be involved. If we could see a particular chunk of a chromosome was implicated, maybe we could think about what genes were on that part of that chromosome and kind of extrapolate to consider whether that gene might be critical for outcome in these patients. And we thought that in the future, this information would kind of form a foundation for identifying cytogenetic subgroups for sequencing or gene expression profiling in further studies. So as of early 2019, when I became aware of this study, there were 110 patients in the study classified as standard risk, so that is their MRD negative. 10 had relapsed. The male-female ratio was exactly equal. And to examine the cytogenetic findings of these kids, we had to have a way of sort of summarizing the very complicated ISCN descriptions of each of these cases. We couldn't just look at the ISCNs. They were too long and too cumbersome. So with Dr. Hirsch's help, I came up with a coding system to encode all of the ISCNs, which we could then use to group patients according to abnormalities and kind of do some statistical abnormalities. And I'm just going to give you a quick example of what I did here. So let's start with this simple example on the top here. You'll see that this patient's got a constitutional trisomy 21, of course, because all these patients had Down syndrome. 8 of these cells showed, in addition to that constitutional finding, an extra copy of chromosome 8, while the remainder of the cells examined in this particular test showed a normal karyotype. This particular patient happens to be mosaic for trisomy 21, and you can see that because of the absence of the trisomy 21 in this second set of cells here. So I coded that +8 as an 8G. That's pretty straightforward, but what about something more complicated, like this bottom string, which gets quite long? Well, here I had a number of different codes that I could use. Oops, there's the code for that. So this patient's abnormal clone had monosomy 7, I coded that as a 7L, had trisomy 8, coded that as an 8G, trisomy 11, 11G, and then this complicated derivative chromosome that resulted from a translocation between chromosome 7 and 11, and this resulted in a gain of material from the long arm of chromosome 7, a loss of material from the long arm of chromosome 11, and that's how, I'm sorry, the short arm of chromosome 11, and that's how I coded that. And then we've got a few more trisomies here, a tetrasomy 21, and this was coded with that particular code. So in doing this, I just had a big spreadsheet, had all my codes, and then I could go through and count how many abnormalities occurred among all of our 110 patients. So here's what we found. I'm just going to start with the constitutional karyotype of these patients. Among big populations with Down syndrome, it's thought that about 95% of them have a full trisomy 21 resulting from non-destruction during gametogenesis, but then about 5% have some variant of this. So they're either mosaic for trisomy 21, or they have an extra copy of just the long arm of chromosome 21 that results from, for example, a Robertsonian translocation with another one of the acrocentric chromosomes. In our study was pretty consistent with that population estimate in that 91% of the patients had a plain Jane trisomy 21 and 8% of patients had some sort of variant of that. And I want to point out that each patient's constitutional karyotype, for example, trisomy 21 in these cases with just plain Jane trisomy 21, serves as a reference normal karyotype for that patient. So when I say a patient had a normal karyotype, I mean that their karyotype was the same as their constitutional karyotype. They all had Down syndrome. So among all of our cases, all 110 cases, about 83% had an abnormal karyotype with cytogenetic findings, the majority of cases. I then went through and looked just at whole chromosome gains or losses. So on this chart here, you'll see that the chromosome number is along the bottom of the chart. The number of cases affected by that monosomy or trisomy or tetrasomy is along the y-axis here. Here's my 0 line. So in blue are the chromosomal gains. In red are the chromosomal losses. So a large number of patients had a trisomy 8. This is really common among kids with Down syndrome and acute leukemia, but it also occurs among other patients with acute myeloid leukemia. So it's not that unusual, although it seems to be a little overrepresented here. Additions of the whole chromosome 21, that's also an abnormality that's seen among non-Down syndrome AML, but it was particularly frequent among these kids. And again, that's a copy above and beyond that constitutional acquisition of an extra copy of chromosome 21. And then chromosome gains in chromosome 14 were also seen, as were losses in chromosome 7. Another abnormality that's seen in other myeloid disorders, specifically myelodysplastic syndrome. What about gains and losses of material within an individual chromosome? Well, this is a kind of complicated figure that's trying to show us just that. Again, here's our normal line right across the middle. These blue bars represent gains of material within an individual chromosome arm. These red bars represent loss of material within an individual chromosome arm. And you can see that there were a whole bunch of different rearrangement, or different abnormalities, all unbalanced. Oops. And I'm going to just point out some that occurred at a frequency of greater than 5% among these patients. So loss of 3Q, loss of material in 5Q, and loss of material in 7Q were seen at a rate of over 5% of patients. And these are all abnormalities that are also seen in myelodysplastic syndrome. Here are some abnormalities that are seen in acute myeloid leukemia outside of the Down syndrome setting, but are overrepresented among these patients. So additions of material in the short arm of chromosome 1, loss of material in the short arm of chromosome 5, and loss of material in the short arm of chromosome 7, as well as, and then we also had that loss of 7q as well. There were some additional abnormalities that I won't comment on too much. And then finally, we were lucky to have a statistician involved at the COG who could run some of these numbers. So he crunched a bunch of numbers and found that none of these abnormalities were statistically significantly more or less frequent among relapse patients than among the remainder of patients. But there were 2 abnormalities, which were not very common among our cases, but which did occur with greater frequency among patients who relapse compared with patients who don't. And these abnormalities were a loss of material within the long arm of chromosome 6 and gain of material within the long arm of chromosome 7. Yeah, Dr. Linden.
Just one quick clarification. Did you look only at cases that were MRD negative standard risk or all cases?
Yes. So yes, thanks for asking that question. That's a good question. We're only looking at the 110 standard risk patients because that unknown number of high-risk patients with who were positive for minimal residual disease is currently censored by the study. So these are all the standard risk patients. Okay, so we kind of felt like that attempt was sort of unsuccessful to identify a bunch of abnormalities that were specific to relapse disease. So we decided to look at complex karyotypes. So complexity of the karyotype is a characteristic of cytogenetic, used to describe cytogenetic abnormalities because it's associated with poor prognosis, both in AML, especially among children, and MDS. The only problem with this particular parameter is that it's, people use different definitions in the literature, so we had to first decide which definition we were going to use. We decided to use a definition used by a study of children with MDS, so not Down syndrome, but just children with MDS. And we defined a complex karyotype as a karyotype with at least 3 abnormalities. One of those had to be a structural abnormality, so not just a gain of 8, a gain of 21, but something more complicated that was happening within the individual chromosome. So that was our definition that we used, and we did find that significantly more patients who had relapsed had complex karyotypes compared with the non-relapse cases. So among the non-relapse cases, only about 9% had a complex karyotype. Among the relapse cases, 40% showed a complex karyotype. So I'm going to give you some very preliminary conclusions. Again, most of these are based on my own statistical analyses, so they don't represent the official COG line on what's going on with these patients' cytogenetic abnormalities. But let's just summarize what Dr. Hirsch and I saw. So the majority of MLDS cases had chromosomal alterations. Absent were balanced rearrangements. Those balanced rearrangements that are recurrent in non-Down syndrome AML, we didn't see a single one of them in all of these 110 patients. Instead, what we did see was a wide variety of unbalanced translocations, including some that are seen in MDS and some that seem to be quite unfrequent in AML outside the Down syndrome setting. And finally, we found that a complex karyotype is significantly more frequent among relapsed than non-relapsed cases. So what are we going to do with this information? Well, we've got grand plans. First of all, we hope to analyze those high-risk cases, which are currently censored. Secondly, we feel like maybe we're not able to achieve statistical significance here because we just don't have enough patients. So we're going to try to code and then combine with this data set the cytogenetics finding from a previous COG study, 0431, which had 204 kids with MLDS. And then finally, oops, I'm missing my last point here. And then finally, our whole goal with this is to kind of lay the stage to identify areas of a chromosome that seem to be associated with relapse and look within that chunk of the chromosome to identify genes that might then be analyzed further analyzed with sequencing or gene expression studies. Okay. I do want to point out, though, that before, this is just to wrap things up here, that Dr. Hirsch and I are planning a study here within the University of Minnesota. And so while the COG is great for this huge study of patients who are in this relatively rare situation, our very own institution, we all know that we've got fabulous material here. So many interesting cases. We have wonderful resources within our molecular group, the cytogenetics lab, within the heme path group, and we are because of this, we really can look at our own cases and answer some of these questions, these outstanding questions about leukemogenesis and prognosis in this group of kids with Down syndrome and AML. And so that's exactly what Dr. Hirsch and I are going to try to do. Here's the study that we've proposed. We have already queried the University of Minnesota Cytogenetics internal database to identify children with Down syndrome and a myeloid disorder who underwent testing here at our lab between the year about 2000 until the end of 2018. We're going to take a look, we're going to code all those karyotypic abnormalities, just like I did with the COG study. And then our plan is to do DNA microarray on the patients for whom we have leftover specimens in the laboratory archives. And in doing this microarray, you will remember back to the case that I presented at the beginning of this talk, that DNA microarray just has an advantage over karyotyping in that it can very precisely define what abnormalities are present in a karyotype. Now, DNA microarray can't tell you where those abnormalities are. Dr. Hirsch uses a sort of metaphor here, saying that array CGH can tell you where the abnormality was born, so where that copy number variation comes from, what chromosome it comes from, but it can't tell you where it lives now. Only G-banding can tell you whether a piece of chromosome 1 has been stuck onto chromosome 14. But DNA microarray will help us precisely characterize the breakpoints and the regions of copy number gain or loss in these cases. And by doing this, again, we're going to lay the foundation for further studies on specific genes or gene expression of those genes and their role in myeloid leukemia. And I'll point out that this is what was done in ALL. The cytogenetics seen in ALL were examined and served as the foundation to direct genetic studies. And this is what resulted in the identification of that subgroup of acute lymphoblastic leukemia, the Philadelphia chromosome-like ALLs. So this is a tried and true technique. All right, so we'll take those cases. We'll look for recurrent abnormalities. We'll look to see whether we can identify any additional aberrations that were cryptic by G-banding that we can see on array. We'll try to identify minimal critical regions that might be important in Down syndrome cases with leukemia. And then finally, we'll try to make a correlation between the cytogenetic findings and either the clinical findings or the outcomes. So, as I told you earlier in my talk, the U of M Cytogenetics Lab serves as the reference laboratory for Children's Minnesota, and we have a lot of wonderful cases here in the Cytogenetic Lab that come from children's. So this study is not just a study at the U of M, it's actually a bi-institutional study that involves both children and the University of Minnesota, which is great. The only downside of this is that this means 2 IRBs. So currently, Dr. Hirsch and I, and actually a whole bunch of other people, are sort of hung up trying to guide these 2 IRB submissions through these IRB groups at 2 different institutions. And it is a slow and arduous process. All right, so this brings me to the summary of my talk. Children with Down syndrome are at very high risk for myeloid disorders. Myeloid leukemia of Down syndrome is unique from myeloid leukemia among kids without Down syndrome. It occurs at a young age. It's preceded by transient abnormal myelopoiesis. It demonstrates unique morphology and unique genetic abnormalities, and it shows very good outcomes for most patients. Cytogenetic testing is key to risk stratification of myeloid disorders overall, but no prognostic groups have been established for myeloid leukemia and Down syndrome that would enable us to develop that to identify that small subset of patients who do quite poorly. So the COG 1531 trial has showed that minimal residual disease negative cases of myeloid leukemia and Down syndrome have a broad variety of unbalanced cytogenetic abnormalities. And in my own statistical number crunching, complex karyotype was significantly associated with relapse. And then finally, proposed research here at our very own University of Minnesota using DNA microarray may further elucidate the cytogenomic landscape of myeloid leukemia and Down syndrome. And the hope of all of this is that eventually we'll understand what makes MLDS patients either high or low risk, and maybe lay a foundation for the identification of targetable abnormalities, or at least abnormalities that are associated with prognosis. That brings me to the end of my talk, and I just want to acknowledge my wonderful mentor, Dr. Hirsch, who has just been incredible over these last few months. I've so enjoyed working with her. And I have also to acknowledge Dr. Dolan, who was willing to sit with me, even at the last minute, to go over this presentation.
I've never done anything at the last minute.
I also want to thank a couple of the people at the COG who are involved with this study, 1531, Susanna Raimondi, who's the cytogeneticist, and then a couple of the MDs involved there, Dr. Hitzler and Dr. Berman, as well as the statisticians, Todd Alonso and Rob Gerbing, who took a look at my numbers. Here at the University of Minnesota, just want to give a quick shout out to a couple of people who are helping me with these big IRB applications, Shelley Polkerbeck, as well as Michelle Rossler, who's in the Department of Epidemiology, and then the folks at Children's Hospital of Minnesota who will be involved with this proposed research and who have been instrumental in trying to get this off the ground over there. Thanks. So I'm happy to take any comments or questions.
I have one.
Yeah,
that was
Dr.
a great presentation. Thank you.
Great, thanks.
For your proposed project,
Yes.
can you say a little bit more about what the archived specimens are that you intend? I mean, what physically is material?
So, the archive specimens, so the cytogenetic lab does their clinical testing on a specimen that they get either in-house or that's sent from the University of, or from Children's Minnesota. They spin the specimen down and get a cell pellet. Some of that is used to perform the clinical testing. If there's anything left over after that clinical testing is complete, the specimen gets archived in the laboratory.
So
And
the cell pellets.
It's the cell pellet, yeah, was that your question? Yeah, so a lot of these cases, not all of them, but a lot of them have leftover material that's, by the IRB at least, considered to be waste material, and that's what we would test by microarray. Dr. Frary.
I really enjoyed that, Amy. My question is about mosaic Down syndrome. And
Yeah.
a little slice of mosaic on one of your slides. My question before seeing that was whether these children, this is all from deep memory, and we have subtle phenotypic findings and various mosaicism, but are they at increased risk of myeloid leukemia as a traditional trisomy 21?
So
classical.
that is such an interesting question about whether children who are mosaic for trisomy 21 are at risk for leukemia or really at risk for any of the abnormalities that affect kids with Down syndrome. And the answer is that Down syndrome, even with full-on trisomy 21, is clinically variable. And of course, when there's a mosaic, the patient's presentations can be quite variable, such that sometimes a kid can be mosaic and nobody knows until that child happens to develop acute leukemia. Somebody runs a cytogenetic test and realizes that all the cells have a plus 21. So I am not aware of any studies that have quantified the risk of acute leukemia among kids with various levels of mosaicism, but certainly kids who are mosaic are at risk both for TAM and for myeloid leukemia, as well as for all the other clinical abnormalities and signs and symptoms that affect kids with Down syndrome.
Did you compare all of the cytogenetic abnormalities in those who had failed therapy or had relapsed with their cytogenetic abnormalities pre-treatment?
Yes, so that's a great question because we would have loved to, it would have been really interesting to see that all the kids who relapsed had maybe an unusual type of trisomy, but that was not the case. Every single child who relapsed, all 10 of those kids had a normal, non-mosaic trisomy 21. Any other questions?
I was just wondering how many cases you actually have from year 2000 to 2018, and then how many of those, tell me, how many of those actually do you have archived specimens?
Yeah, so that's a great question. So we have 34 cases of kids with Down syndrome and myeloid disorders. So that includes both kids with acute leukemia as well as samples that were drawn from kids with TAM. And sometimes with myelodysplastic syndrome in Down syndrome, But MDS and acute leukemia are kind of lumped together in kids with Down syndrome because the biology of the disease is so similar. So I can tell you how many cases we have, but I can't yet tell you how many archive samples we have. I don't know that answer yet, and we've kind of held off on doing too much of this study before we get IRB approval. Yes?
Was there any interest in the ALL side of the Down syndrome?
There is plenty of interest out there in the community, absolutely. But my particular project focuses on AML. But yeah, kids with Down syndrome are at increased risk for acute lymphoblastic leukemia as well as AML. But it tends, ALL in kids with Down syndrome, I think, tends to look a lot like, has similar outcomes, similar cytogenetic findings as ALL does in kids who don't have Down syndrome. But that's about all I can say about that. Yeah, Dr. Furry.
That was really a great talk.
Thanks.
Just an FYI, much like the bioinformatics people we have over the supercomputers, we now have an arrangement with the biostatistics group that's up the street from the hospital. So
our department does.
Yeah, so it's a bunch of faculty from epidemiology that have a core competency in biostat. I think there's up to 15 professionals working there. So we'll get you the information. You could have them help you with just your local analysis if you want.
That is a great idea, and I think will really help when it comes time to do those stats. Thank you.
Mm-hmm.
Yes. So you'll see my husband and my son Charlie are here today. They've been holding down the home fort while I prepared this talk.
And so I have a question.
Yes.
Is there what is the definition of a complex karyotype quantitatively? How do you make that ascertainment?
So I'm not sure what you mean by quantitatively, but to define it all, a patient for our purposes, we defined a complex karyotype as a karyotype. So and this can be in one or multiple clones in a single patient. A karyotype that shows 3 or more cytogenetic abnormalities. So that can be a trisomy where there's an extra copy of number 8, that could be an abnormality. A monosomy 7, a loss of chromosome 7, that could be an abnormality. But among those 3 abnormalities, 3 or more, there has to be at least one structural abnormality. So something beyond just a gain or loss of the whole chromosome, something that affects the material within that chromosome. So either a deletion within one arm of the chromosome, or a translocation, or something that's not just a whole gain or whole loss. But many of these cases have more than 3 abnormalities.
So following up on that question then, so actually that's a really good question. I never heard this question asked before. So how actually, so what sort of the biological output of these complex abnormalities,
Yes.
and how would you quantitate that?
It's, okay, so I'm not 100% sure that I understood that question, but I think it's really interesting to think about why is a complex cytogenetic karyotype, why is that associated with a poor prognosis? So something that I didn't say when I answered Kenny's question about complex karyotype is to say that each of those 3 or more abnormalities, or however you decide you're going to define a complex karyotype, each of those abnormalities has to be independent. So sometimes in cancer, we see chromosomes that are just all screwed up. So they might have an insertion and a deletion and a duplication, and then half of it's fallen off and associated with a different chromosome. But a lot of times, abnormalities within one chromosome, even if there's a number of them, are not considered to be independent. Instead, they're probably related. Probably some catastrophic event happened to that poor chromosome to result in all of that crazy loss and gain or reconfiguration of the material within that chromosome. And I think that's important to consider when you think about complex karyotypes, because probably, this is just me talking here, but probably complex karyotype is evidence of genomic instability. And so it's not so much the specific abnormalities that make up any individual patient's complex karyotype. It's just the fact that the chromosomal material is really screwed up, which is probably evidence of a biologic process, chromosomal instability, genomic instability, that is related to oncogenesis in general. Did that answer your question? Okay, maybe we should wrap it up. Thank you everyone so much.